going to be having a conversation about implementation of digital mental health treatments. And I have with me today Trina Histon, who got her PhD in health psychology from University College in Cork, Ireland. And she worked for around 20 years with Kaiser
Mhm.
Permanente and oversaw the development and implementation of their digital mental health platform. And then she left there to go to Wobot. And Jenna Carl is with us she got her PhD in clinical psychology from Boston University, and for the last, I think, 8 or 9 years has been with Big Health, where she is currently the chief medical officer. And I'm David Mohr. I'm the director of the Center for Behavioral Intervention Technologies and the current president for the Society for Digital Mental Health. So I want to just give a little background on kind of the impetus for this webinar. So um, the society this was we put this is we published or through the Society for Digital Mental Health a digital mental health treatment playbook a few months ago, and the society is SDMH is a big tent organization. It's got, in addition to academic researchers, there are a lot of companies, representatives of companies who are there, healthcare systems, and a lot of other stakeholders. So it's a big tent organization. And one of the things that we were seeing is that there's a fair amount of implementation of digital mental health going on in the United States, as difficult as it is in the current environment. And none of this was really getting out because it's generally being done as kind of a business arrangement between companies and healthcare systems. And so we put together this work group that included around representatives from around 10 companies and around 7 healthcare systems that had engaged in implementation to surface kind of what's working and what's not, to come up with kind of a set of best practices as best as we can say at this point in time. Um, so that's what we're going to be talking about today. We'll be having a conversation for the next 40 or 45 minutes or so. And after that, we'll open it up for questions. So there's a Q&A button at the bottom of your screen. So go ahead and, if you have questions, go ahead and put them in there. And we'll get to as many as we can at the end of this. I'll also put in a few minutes. I'll put links to the playbook documents in the chat. So I'd like to you know uh, to to begin the conversation kind of chronologically. There's been a there was a lot of consistency in the work group in kind of that a staged model for implementation was useful, beginning with a pilot, which is typically kind of small, 30 to 50 patients, in one setting, and essentially to give the team a chance to work through all of the things that go wrong in implementation with a smaller group of people, and then to begin scaling, and then finally moving into sustainment. But before you begin that pilot, there is an awful lot of planning that has to go on, and so I'd like to start there and maybe we can talk a little bit about what are the goals of planning and who's involved. What is that process like? Do either of you want to start? Trina, do you want to?
Yeah, I'm happy, and thanks again for the invitation to be here, David. This topic is near and dear to my heart. I think first of all, I'll say the opportunity to partner, if you're an industry, with the healthcare system, or a payer. So it depends on who you're partnering with. The opportunity can come from many places, but I think you really want to be thinking about your stakeholder mapping. So you may have one conversation and think, okay, this is great. We're sort of in with this system, but really you're just beginning the first step of a long journey. So on average, just contracting takes about 18 months, 12 if you're really quick, and if the health system has a lot of experience. But who are your stakeholders? So obviously, when you're thinking about digital mental health, you're thinking about clinicians. Is it primary care doctors? Is it psychiatrists? Is it therapists? Or all the specialties in between? What's your care setting? So the clinical folks would be one stakeholder. Very important to understand where are their pain points and what are they trying to solve for. But you'll also be talking with folks in operations because they are looking at a continuum of care. and standing up services operationally, and how might your solution fit in that continuum of care? Who is it best for, and then who is it not for, as you think about that implementation journey? Don't sort of ignore the IT folks, especially even if it's a pilot and you're starting very IT light. You'll want to understand their worldview on how they see integrating solutions like yours into their ecosystem. And then also don't delay on bringing in folks and contracting and legal, because that's where you'll have some of the most fun conversations. But trying to understand the different parts of the system you're working with, where are their pain points? What is their sort of kind of shared belief around the opportunity that you bring? And, I know folks in sales are always like ABS, always be selling, but my moniker is ABL, always be learning, always be listening, and always be leveling up in terms of the information. Every conversation you have is almost like a mini MBA if you stay open to what you're hearing. So I think they're the things that set up a pilot well, because you're understanding it from as much as perspective of the whole system as you can. Jenna, what would you add to that, given your experience?
I love that. I gotta keep the ABL moniker. Uh, yeah, what I would add to that is having real clarity and probably written down, like could be in a letter of intent, if not,
Mhm.
in the actual kind of drafting of a contract, but real clarity about what the purpose of the pilot is, what the success criteria are, and what happens like following that pilot. Because I think, unfortunately, it can often through everyone having best intentions, I think you can often get into pilots then that don't end up going anywhere, and they can take a lot of time and resources from both the health system and the digital health provider. So and there's a lot of opportunity for misunderstanding. So, for example, one thing that we have repeatedly had to ensure when we actually try to avoid the P word pilot because
Mhm.
we're saying, what is the purpose of this? Is it, and it's really to design the model for scaling beyond that first phase. And so that's what we would think about as the initial phase is it's not to test efficacy, right? We're coming in with a digital treatment that's been proven if clinically effective and safe in RCTs, randomized controlled trials. And so we want to be sure that the health system understands that this is not, relitigating efficacy, and that can be a point of confusion. And because then, there's all these people in the health system that will downstream have no idea what was initially discussed around the plans for the pilot, and they'll see something in the data that they're, well, wait a second, like, that doesn't seem like enough change on this measure. And so I think the point is to really be clear about what you can test and what you're testing in that pilot or phase one, and then what really you want to ideally have clarity about with the health system about how you move from phase one into a phase two, and what does a phase two look like. So that would be the other thing I just would be very very kind of cautious of, and kind of setting up and designing in
Mhm.
that planning phase to get real tight alignment on the goals.
Yeah.
Yeah, you mentioned Jenna, sort of the you want to part of getting all the stakeholders involved early on is so that they that they're not going to be misinterpreting the data that's coming in, that everybody's on the same page. But what are some of those data? I mean, I think we're talking essentially about sort of key performance indicators,
Mhm.
KPIs,
Mhm.
or
Yeah.
what are some of the kinds of KPIs or things that are tracked?
Yeah. Well, I think in implementation, it's important to set those differently than you would set as like the clinical success criteria in a randomized controlled trial, because like I said, otherwise it just will be misinterpreted. And so I
Right.
would think about, and Trina, I'm sure you'll have a lot to add to this. But I would think about if it's from an implementation context, what are those, like you said, KPIs or early indicators of success? So if providers are required to distribute or offer the digital treatment, then one of those KPIs could be how many providers are trained. Another could be how many providers offered the treatment within the first month. So they're practical outcomes where you're assessing the implementation, you're not
Hmm.
assessing the treatment per se. So that would be those would be a couple examples, but of course there's many more. I mean, you usually would have, a handful, five. Like you don't want too many success criteria or too many because it can get even more complicated, but 5 to 7 kind of key
Yeah.
KPIs that you're looking for.
Yeah, I agree. I think 5 to 7 is a good number, and if you think about where you're starting in the pilot, your KPIs will mature and change over time as you get to sustainment. But I think to underscore the provider engagement piece, because you can have the best solution, but if it's not getting in patients' hands, it's just a great solution that nobody knows about. So being very intentional about how you're learning about that provider adoption curve. In my experience, it's anywhere from 30 to 60%. And actually, there's been some really nice work done at Reliant, at Dr. Sam Norberg, that has it in the 90s because they have a digital navigator to do the follow-up. So the system of care will really actually impact provider adoption, but it starts with that trusted conversation between a clinician and a patient, and then somebody being willing to try it. I'd also say another thing that is important if you're deploying in a health system, clearly people are getting referrals. Maybe they're getting referral to behavioral health with primary care, or a referral to another sort of either a group class or a group situation. So looking at that speed to support, what percent of time is passing before somebody takes up the referral they received, versus maybe other aspects of care like a referral to behavioral health. That's something I've experienced where the digital realm can get you a much faster speed to support than potentially the wait lists that we know access is a huge pain point globally. I'm sitting here in Dublin, Ireland, and it's no different here. The need is greater than the ability to provide for it in most countries at this point. But don't overcomplicate those KPIs. Obviously, you want the leaders in the room to agree with those and then track those and communicate those. Don't just set it and forget it. Like keep them in front of folks because they are the important data points you can bring back to those early adopter clinicians. Say, here's what we're learning. Maybe the clinician adoption rate's 10%. Okay, how do you get that higher? Where are the barriers? Is there friction in the process? Is it a sort of a belief that this tool can be valuable? Is that where the issue is? And you really begin to unpack that from the data. So bring the data and bring the stories because they're incredibly powerful.
Yeah, so what I'm hearing you say is that these KPIs or measuring some of these metrics are not just determining whether this is successful or not, but it's also providing data throughout the process that can be used to identify where there are problems,
Absolutely.
what kinds of
Yeah.
because anybody who's done implementation knows that a plan is
Yes.
rarely survives contact with reality.
Yeah. Yeah. It is. It is. You got to keep sort of learning and testing the boundaries of what you're learning, what data you're seeing, and what's really happening to get stronger. Because I think of people, processes, and technology, and the people are so important in this whole equation. We're talking about technology, but if the people are not sort of bought into the process and they can see the value, and if the process doesn't support the people, the technology doesn't matter. So you've got to always be thinking along those three dimensions to support the care teams and ultimately support the patients as well.
It always goes back to the people.
Absolutely.
And you were maybe use that as a segue. You were talking about the importance of how the referrals made.
Hmm.
What have you seen that works, and what have you seen that doesn't work in terms of getting patients connected with a digital therapeutic or registered?
I'm happy to start, Jenna, and then feel free to come in. So I think if a clinician, and it's unusual with technology, right? You don't have a clinician trying perhaps every drug that they've prescribed, right? So technology is a little bit different. They can actually kick the tires and experience your solution. The more knowledgeably they can speak about what they're referring you to and how it's going to help you in your moment of need, I think that is the gold standard. And so I know clinicians are very, very busy and they've got very, very limited bandwidth to be looking at yet one more thing. But I found that is really a difference maker when they can say, well, I actually tested this myself and here's how it helped me, whether it's for managing through a stressful moment or helping with sleep or helping with the stressful event. So that is really, really key. If it's very clear that the referral might be followed up with somebody who will talk to you in a little more detail, like so that digital navigator role that we see at Reliant, and Dr. John Torres talks about it quite a bit as well. I actually think that's one of the roles for the future, and they just do amazing work because they're not clinicians, but they really understand the solution and how to connect somebody. So it's that people connecting the process and the technology. So that's one thing that really works. And also being able to say, my patients have found this really valuable with the kinds of things that you're struggling with. So personalizing that referral is so important. Generally, what doesn't work is if it's very lightly talked about in the visit, and there isn't really a clean sort of process for referring afterwards. So having that follow up in my chart, if people are using Epic with the clear criteria to download, you want to remove as much friction as possible, because the clinician has kind of done their job in saying, here's how I think it's helpful, but the system then cannot fail you after that. It's got to be clean all the way through. So if somebody says, here's something, it might help you, I'm not quite sure, that's unlikely to be taken up as a referral. So personalization is key, leveraging that trusted relationship that the clinician has. And if somebody is going to their doctor, we know it's about 11 years from when symptoms first happen to when somebody seeks care. So they've been sitting with something a long time. So you want to make sure that process is very easy for them to receive that referral as well, and not full of friction. So they're just some high level things I think about. Jenna, what would you add to that?
I would just add that interestingly, we found it is a lot like getting a patient on board with starting CBT, or call it a behavioral intervention, where I think you just digital, like CBT or like behavioral intervention, suffers from not fitting into a lot of people's mental model of what treatment looks like. And so I think this is one of the things we instruct providers offering like big health treatments, sleepio for insomnia, et cetera, is we say, look, pitch this just like you're pitching CBT. I mean, that's what they're getting, right? But explain that, like, even though this is in the form of an app, what this is offering you is what's the gold standard first line of care for insomnia. It's behavioral techniques that here's how they work. If you do it this way, like here's how it can help you. And so it is, aside from I mean, there's the two pieces. They're like, it's digital, even though it's digital, it is an effective treatment. And here's why, and here's what it is. And then the second piece is really like how a behavioral treatment works. And so I think if a provider can articulate those things, I think it goes a long way. Very much in addition to what else Trina said, because I think otherwise it is a lot about it's that accountability and confidence of the provider in making that recommendation. But having a follow-up, right? If you just offer it and then never follow up with a patient,
Yeah.
like, it's the same. I mean, just using the behavioral strategies that we all know of saying, I wouldn't you I I want you to try this. I'd like you to get started this week. I'd like you to try to use it this much. I'm going to check in next
Hmm.
week, see how it's going, right? So like
Yeah.
close the loop so they're not,
Hmm.
you know, people get nervous and anxious about starting new things. You really want to check in again.
Yeah.
Yeah, so it sounds like, being really specific about what the expectations are, kind of a more, Trina, you kind of talked about what sounds like almost a personal endorsement, I've
Hmm.
seen this, I
Hmm.
like it. And then, it also sounds like follow-up. And I always, uh, come back to like benchmarks, like, referrals, like when a primary care doc makes a referral to psychotherapy, only about 10% of patients actually follow up.
Ah.
And we have the opportunity here, I think, to do a much better job, because it's more in our hands to be able to support patients
Hmm.
in connecting. And the numbers out of Reliance seem,
Hmm.
I don't remember, it's like in the 70s, 80%
Yeah, in
getting
the
connected.
90s that I've seen.
Um,
Yeah, there's no reason why we can't 4 to 6x the uptake here, none whatsoever. And that's the beauty of digital is scalable. You can touch more people and reduce that burden of suffering, which I think all of us on the call are plugged into. So we really should be there by now, but we're at a new base camp. That's kind of how I look at where we're at right now with digital mental health.
So when we were in the work group, one of the things we spent a lot of time, I know, talking about this issue because it's such a critical point in the process. And one of the things that you remember walking away with, was just a long list of things that the clinician needs to do. And I'm
Hmm.
thinking, I mean, primary care docs have what,
Right.
7 minutes, 10 minutes with a patient, and people who are dealing with depression or anxiety or emotional
Hmm.
problems can take up a fair amount of time. So I mean, can you speak a little bit to, like, in your experience, that balancing the need for efficiency with efficiency with the support for the patient to get connected and get started?
Yeah, what I've seen work, and again, from your point on the literature, it is about 17 minutes the primary care doctor has, maybe less in some systems, and they're covering 6 to 7 topics. So now you're hoping there's time to talk about your solution and how it fits in with the plan of care. So it absolutely has to be simple. We reference digital navigators. Obviously, when you're starting out in a pilot, you may not be fully integrated into EMR. You really sort of want to start quickly, so you may not have that full integration. But what I've seen the rise of, which I think is fantastic, because again, it takes the burden off the clinician's shoulders once they've done the referral, is the middleware like Xelt and Oracle, making that orchestration layer easier to pull the sort of referral through. So there's the documentation, and then there's the follow through that the patient can act on, and of course, very importantly, building in those nudges because. In my experience, if somebody doesn't, I've seen referrals go as many as 14 days before somebody says, "Oh yeah, my doctor did say something." So there is the ability to nudge, with my chart and with other systems that I don't think we've probably leveraged enough in the implementation model. I think health systems will make the referral, and then we don't want to be clogging the doctor's inbox either. So there are mechanisms now coming into place where those additional nudges can happen probably no more than two. Again, in my experience, more than two, you're not getting the value back. So, the technology is supporting line of sight on where is the process breaking down in the end-to-end pathway, and how can we make it easier for the care teams, because you really want to. It shouldn't take more than 40 to 60 seconds, and I know they're precious seconds for a clinician to speak to. In a primary care setting, to speak the tool, and then the system really should be simplified thereafter to support that referral, just as you would getting a lab or getting a medication, and it's very clear in the after visit summary where you go next. I think we probably don't have enough full cycles or publications about what that looks like yet, but I've seen it happen where we can get those numbers up. But very important that you're showing value back to the care team, so the data is coming back to them in some way, so they know you're reinforcing that loop that this is helping their patients.
Yeah, I mean, I could not agree more with that. We've actually worked a lot with primary care physicians in the UK,
Hmm.
and I think despite all the challenges, it's worked very well. I think to Trina's point, it actually does not take long once they
Hmm.
get down, like how they explain and recommend a program. So that part is pretty quick. You do need to do good provider training up front, which is, I mean, that
Hmm.
it is a challenge to get provider time initially, but so there are lots of ways of working on that, and I think you also rely somewhat on network effects. Like you get a core group of sort of early adopter providers trained, and then they start spreading the word. There's a lot of provider to provider bringing people along, but we've just, again, I mean, hopefully you're solving a big enough pain point that the providers are motivated. In the UK, they're really focused on deprescribing sleep medication. So for us, with like our insomnia
Hmm.
treatment, that was very helpful in getting their attention initially. But then, like once, I mean, it's not really complicated to offer a program once you kind of get it down.
Yeah.
So that would, yeah, I'd say those are that you need to be serving a gap that they care about. But other than that,
Hmm.
it's not that hard.
Yeah,
Yeah.
I just want to follow up on something you
Sure.
said, Trina, which was you mentioned giving feedback to the the
Hmm.
the the prescribing physicians or prescribing
Yes.
clinicians. Um, and I think for a lot of providers, this is new. It's not something they learned in medical school or in their training. And providing that feedback, it sounds like, can help
Mhm.
reinforce the changes in behavior that you have to see in clinicians.
Right, right. So if I think about, in my experience, it's usually, showing if you're launching at a couple of different sites in a system. So they're the early adopters in a classic innovations curve. You want to be able to provide, depending on the N, overall how things are going, how many patients came in each week, and then do it by site, depending on the kind of metrics you have. So, minutes, lessons, sessions, time of day, changes in PHQ GAD, like whatever your metrics are, being able to show that and localize it as much as possible while preserving the confidentiality. So, there's a fine line to that, but very important to do. And then contextualizing, here's how site one is doing, and they've referred a lot, but maybe their adoption is lower. Site three referred fewer, but their adoption is higher. What could be going on there? Like really kind of piquing the curiosity of what's happening. If your clinical lead can take that data to, they all have huddles and they're checking in with each other and bring that data and then ask those questions, and then that peer-to-peer learning comes in, and that is just so important because then the system is learning from itself, and I would say most health systems consider themselves learning systems. So then they can bring that knowledge to the next wave of sites that you launch. So they're the kind of things that work really well, and I would say if you have the opportunity to do a kickoff live, with your clinicians, bring food, and I'm not being pithy when I say that, but feed them. And then always have an empty chair in the room where the table tent reads patient, because they should be in the room if they don't have patient panels or they're not brought into the room for kicking off the process. Represent them in the room because that changes the conversation when they walk in and see, oh,
Hmm.
okay, if there's a patient here, what would they say? So you're really leveraging those human-centered design methods and bringing the patient into the room. And it just to me, it leads to a richer conversation. There's some of the things that have worked.
All right, I love that idea of if you don't have a patient there, having a chair there
Hmm.
to represent the patient,
Hmm.
keep that top of mind.
Yes.
Uh, so we've gotten a patient connected. Then how do you keep that patient engaged in the tool? I mean, we know, I mean, even with psychotherapy, you know, people drop out pretty quickly.
Uh, uh,
Digital mental health is no, we can't expect it to be that much different. So you're dealing with people with depression and anxiety. They're anxious, they're procrastinating, they lack motivation. There's all kinds of, we're fighting against the problems that people are coming in with in
mhm.
many cases. Um, you mentioned having the clinician follow up with the person. Are there other things other ways that you found are helpful in keeping people engaged?
Yeah, I mean, I think it depends on the solution. So,
Mhm.
Jenna, with Big Health, you've got Daylight and Sleepio, and in my prior experience with Wobot, Wobot for adolescents and Wobot for adults, and very different products, configurations, and potentially populations touching. But when you think about CBT, are you setting an expectation that somebody's coming in every day to do something? You obviously want to be specific about early use because that will then dictate. But I think then you want to say to the person, like, come in and use it as you need to because life happens, right? You're going to have something happen that maybe your sleep is off, or you're having relationship issues, or preparing for a stressful event. And then you'll want to dip into the toolbox again. I mean, CBT as a construct, you're a toolbox that you're dipping in and out of to support your life, and learn those things if you go back into rumination or you're back in the cognitive reframe. So I think within the apps itself, obviously, um, thinking about notifications and how you're using those. Is it the same thing at the same time every day? How much agency have you given the user to say when they want to check in, and then life happens and like, no, I don't want that right now. So not sort of nudging but not nagging. I think it's a fine line. You want to really get to that right away. And then, obviously within the solution, being able to show somebody, making progress. Like people love to track their mood, even if it's with an emoji. Obviously, you've got PHQs and GADs on the clinical side of things, but showing somebody where they're at in their journey, and that every time they engage with the psychoeducation, they're learning something new or a technique. They're sort of building out their foundational skill set, and that's kind of over time. But you will find people like leaving for weeks at a time, and then they're going to come back when something in life happens. So, there's something about how long is the expectation that somebody, what's a course of treatment? I've seen that, in the literature, and I think. Depending on the kind of solution you have, there absolutely is that, and obviously Jenna can speak to on the PDT side what that is. But you also want to let someone come in their moment of need and leverage your tool that way. So, uh, having your early imprint and experience with the solution being this is where I go when I need help, because you either have folks who will use it quite a lot and they'll do journaling and they'll do breathing techniques, or they'll come in when they're having a hard time. And there are really no two users the same on some level. You can segment a number of ways, but it's not one size fits all. Never has been, and it never will be, because it's the nature of us as humans.
Yeah.
Yeah, and I mean, and on that, I was going to say, I think this is where there is some real work that the technology can do. Now, we're still in this phase that I think we're kind of bridging from the kind of 1.0 version of
Uh,
digital interventions to I mean, yeah, maybe we're 2.0, which is still kind of behind, like if you think about consumer tech.
mhm,
But as you start to see like consumer tech learnings about how to keep people engaged in a technology program, like kind of best in class examples are like Duolingo. Like
mhm,
when you start to apply some of those principles that are just what Trina said, it's like it's figuring out how to nudge people at the right moments, and then when
mhm,
they're in the program, how to set up a model of how they use it such that that's reinforcing, that's really clear, that is that provides enough kind of structure and accountability and cadence that they can really get into a rhythm of using it. Those principles lend themselves very well to CBT. In fact, when people talk about that coming from behavioral science, not I'm always I was like that. I mean, that is CBT too, right?
mhm, mhm,
But it is, but I think that can help a lot with getting people to use digital treatments as intended. And it's just going to increase those two principles are going to increase, design principles will be increasingly used in digital treatments. So that's a big piece of it. And I still think though, like if you look at the literature, it's a bit out of date because and I mean I haven't looked at this recently, but I mean maybe a year ago, I think I would still kind of commonly hear people say, oh, well, you know, pure digital gets no engagement. You've got to have coaches or something like that to get engagement. And I think that that's largely based on literature where you're going back to like these very early versions of digital treatments that were incredibly basic, clunky user experiences. A lot of it was like just text on a screen
mhm,
and it's just technology moves so quickly. I don't think that that's relevant anymore. Some of those data aren't relevant anymore. It's and then so I would still say obviously you can use humans really nicely to improve engagement, but I don't think that's the only option. And I think you want to be kind of thoughtful of how using kind of both in the right ways. So I think,
Yeah.
and to Trina's point, like digital navigators can be done
mhm,
really well. I think the way Reliance done that is incredible.
mhm.
But there's a lot of opportunity to kind of do that within technology as well as do it within the kind of implementation around it.
Yeah, and I know this was a topic we talked about in the work group, and I know we've seen when we've done implementations that around half of people don't want to talk to anybody.
Mhm, mhm.
So again,
Yeah.
people are different. People want
Mhm,
different things.
Yeah,
So
great
even if
point.
it's available, they don't really, they don't find it useful or don't want it.
mhm,
Yeah, great point.
Yeah, so um in the care pathway, and I guess this is my own personal bias. I'll put it out there, and I'd encourage you to disagree with it but my fear with digital mental health is that it'll, if not properly implemented, it'll just be one more treatment that's out there, and that a fundamental problem with our mental health care system in this country and probably in most countries
Hmm.
is that it's fragmented, that there's no follow-up, there's no continuity. We have, and we see that, for example, like with collaborative care, where you have somebody following the patient, that the impact of collaborative care is far greater than any individual treatment by itself, because you can move people to what they need. And, you know, I think both of you have, work or have worked with great companies that have great products, but it's not going to help everybody. So
Right.
how do you see how should these be implemented in care pathways, within healthcare systems? And and how have you seen them implemented, and what works and what doesn't work?
I
Yeah,
mean, I'm happy
Jenna.
to take a first pass on that. I
Yeah,
don't
go
know.
for it.
Because I think this is something that like was part of the reason I joined Big Health way back 9 years ago, and really what I think is so important to the future of mental health is, to your point, is there. I think mental health care treatment should be part of healthcare, should be paid for by insurance, the same way that other, physical health is treated. And where and digital health has, I think, been struggling with that for a long time, where if you look at like how it's integrated, how it's paid for, it's very often on the fringes. It's direct to consumer, or it's like piecemeal. You get one health system to say, oh, we like this program, so we're gonna fund it out of some, some funding somewhere. But it's like it's not scalable. That won't work in other places. And so one of the things we've been really focused on a big help was figuring out what a pathway would be that it would allow for highly qualified, proven digital treatments to be integrated in care in some type of systematic way. And so I think the current model where I think that's going, and that could shift, but is with the type of coding that CMS created last year, which are they're G codes, but they're essentially like CPT codes. So they're provider codes. So the codes that psychologists would use or physicians would use. Where what's interesting is that coding model has put together the provision or supply of a digital treatment with the provider-led onboarding for the patient. So it makes it a service code. And what that means is that that's a scalable, routine part of healthcare, mental health care, that we're not going to be going away from anytime soon. And it also puts providers at the center of offering digital treatment and integrating them into care, which is also kind of a central kind of common pathway for delivering treatment. Um, and so I think that that's a good model for going forward. Now there's still issues with there not being full payer coverage of codes like that.
Mhm.
So though Medicare is paying for those codes, and some commercial payers are, not everyone is, which you would need that kind of broader coverage for it to become really kind of mainstay. But that typically that does happen once Medicare, starts covering something nationally, the commercial payers should follow. And I think that gives like a model for how other digital treatments can then be integrated into care. Now there are some prerequisites of that model around like needing FDA clearance, needing to show medical necessity, needing to be treatments of a condition, those types of things. But at least it's one model for digital treatments that are attempting to be kind of on par to other mental health treatments, something that could be offered either instead of or in addition to like therapy or medication. I think that is a pathway for that type of digital treatment. But I mean, Trina, David, I mean, jump in and tell me if you see other kind
Yeah, no, this is great. This is great. So we'll
Yep.
segue into reimbursement here, because
Yes. Mhm.
fortunately or unfortunately, depending on your perspective, healthcare in the United States is a business.
Yeah.
And just to follow up on what you were saying, Jenna, in case people don't know, the Centers for Medicare and Medicaid Services issued, starting January of this year, three HCPCS codes or G codes: one to pay for what they call the device or the product, and then two for clinician support in 20-minute increments. So there's actually now the beginnings, and there's lots of problems with it, like everything
Mhm.
when it's first out of the gate. But Jenna, I know you've had some experience with this, and Trina, I think you also have. So yeah, what is the state of reimbursement now? How is that working?
Yeah, I mean, so I think yeah, what you laid out is right. Starting in January, Medicare fee for service and Medicare Advantage, based on that CMS final rule and the physician fee schedule, is covering this. Right now, they've just defined it as a narrow category of what they've called digital mental health treatments,
Mhm.
and that the requirements are that the digital mental health treatment must be not only FDA cleared, but FDA cleared under one specific classification, which was for the computerized behavior therapy of psychiatric disorders. And not to kind of get too much in the weeds, but the way FDA classification works is like once there's kind of a precedent, which the initial clear regulation for that computerized behavior therapy for psychiatric disorders was from Pear Therapeutics for substance use.
Mhm.
But then other psychiatric disorder treatments can follow on under that same classification. And the reason that CMS picked that as the key classification that they said they're recommending for coverage is because that classification required clinical data proving the behavior therapy model within that digital treatment. And so that gave them confidence that this would be evidence-based behavioral treatments. And so there's only like seven
Mhm.
digital treatments cleared under that classification. Some of them are not currently in the market. It's a very narrow start, but like kind of we were talking about a minute before, it does present a pathway forward. So other like now, like other digital health treatment makers can follow that pathway. And the reimbursement is happening. So Big Health has two treatments that do fall under that classification. Um, they're Sleepio for insomnia, Daily for anxiety, and we are seeing providers use those codes, get reimbursed. Um, I would say one thing that's interesting for practitioners is that certainly the first code, as you mentioned, David, the code that covers the supply of the device and also the time for the provider to recommend and onboard their patient. That code is irreplaceable. Like that's what the kind of game changer is, that without that code, providers couldn't offer these treatments before. But then there's also these two treatment management codes, which are structured a little differently than a lot of behavioral health clinicians would follow their patients, because there are these 20-minute increments and they can largely be asynchronous. There's only one in-person synchronous visit required for the month to use as many of those like 20-minute increments as needed. So it fits a little bit more of a model, like if you imagine there being like digital navigator support or coaching support. So I'm talking to, you know, psychologists and physicians that want to use these codes primarily. And they're sort of some of them are thinking, oh yeah, I've got someone in my practice that could use those treatment management codes. And others are saying, well, I'm going to be seeing this person for therapy anyway, or on a weekly basis. And so I don't need to use those other codes. Like I'll just check in with them at, the other visit. So it's all to say that reimbursement's happening and providers are actually actively using these codes, figuring and getting reimbursed and figuring out how to use them optimally in their practice, which will vary a little bit from any, type of practice based on the types of providers and et cetera. But it's beginning to happen. And so I think it's very cool. I mean, frankly, we'll learn from them, right? They're like on the ground experimenting. And
Mhm.
so we're learning a lot. Like I'm just having calls talking to those practitioners on a, weekly basis. And like, they're just figuring all kinds of interesting things out. And so I think it's a really exciting time from that standpoint.
Yeah, I would just add, I think you're right, Jenna, about seven. So big health is about 29% of the solutions are getting reimbursed on the market today. And um, I was struck by earlier today, I was looking at the MedPAC April meeting minutes, which is multiple hundreds of pages long. But if you Google MedPAC April 2025, you'll see the PDF document. And starting on page 227 is the discussion around digital therapeutics. And what I'm struck by is like these are incredibly smart people that sit on MedPAC. They and the Macs trying to set the price points. They too are really trying to understand how does a PDT differ from software as a service, and they're also very, very conscious of setting price points that could come back to haunt them. I think is some of the verbiage because I think some of them might be $1,000 in their history if they think about when we think about pair and reset O. And there's one quote that I took that I really like because I think it points to the challenges we're at. Nobody would expect a 1965 Studebaker to deliver a contemporary experience. Many of the tentacles of our origins in 1965 are strangulating us today. So they're learning, we're learning. I would say, what Jenna reflected is a new base camp. And Jenna, you've got the crampons on and you're scaling that new hill. But now there are codes, and I think that's tremendous. And I think I think many of us on the phone might have advocated for a broader view. And to start with, they took a narrow view, totally understandable. But once you have that first steps in, I think the opportunity then is to show the value. But they're still trying to understand what are digital mental health therapies and not wanting to, in a decade's time, come back and see that they didn't get it right. So you're kind of really navigating new territory. And what I've seen, and maybe some of you guys follow Brian Dolan, Exits and Outcomes. I get the email every Friday, but he's reflected that what he's seeing in the landscape is a reimbursement of about $129, which I think all of us in the field look at the cost of doing the studies, the cost of getting to market, etc. That reimbursement rate, probably isn't sustainable. And as you said, David, it is a business, and with access being so challenged and digital having such an opportunity to scale, there has to be a new sort of balance point there that we're nowhere near yet. But the story is being written as we speak, which is fantastic.
Can I just chime in one thing just to say, because I do read Brian Dolan, and I unfortunately I feel like he confuses people a lot on some of these points. So
Uh-huh.
there was one Mac that set that low price of
Uh-huh.
129 out of the gates without information on the new codes. And I think that it's not uncommon that can happen in kind of these early stages, but I don't think
Yes.
anyone, yeah, I think they've received a lot of feedback.
Hmm.
And and the other Macs have not done that.
Can you
And
just
Okay.
define what a Mac is for people that aren't as well versed as?
yeah, fair point. So Medicare administrative contractors. So there are essentially there's different ways of dividing it up, but there's essentially seven
Hmm.
entities that set prices for different regions, and we call these the MACs, the Medicare administrative contractors. And this is it's a temporary situation in that CMS will eventually set a national price, but because as Trina said, which is very correct, when this is early, and so they don't want to have to walk backwards if they get the price wrong initially. And so what they're looking is to get data on like what the market price actually is
Hmm.
over the next couple of years, and then that can help inform a national price. But in the interim, these different Medicare regional groups set those prices, and they set them each independently. And this often happens where like they set different rates. It causes a lot of confusion.
Hmm.
And then various providers will go to them and kind of request repricing. There's other industry groups and that do that as well. So it's all early and shifting around,
Hmm.
but I did want to clarify because we heard a lot of people see that price from Brian Dolan and think that's the price, but that's actually it's a limited segment, and they are
Hmm.
certainly getting a lot
Hmm.
of feedback on it. So there's other
Good.
examples
I'm
of,
glad that you
yeah.
clarified that.
Right.
Thank you.
I want
Yeah.
to jump to. I could keep talking with you guys for another 2 hours, but I want to get to a few questions here that have been coming in. So the first two questions, I think we may have kind of answered. They came in earlier, but one here is just saying that they haven't had success with their digital interventions, and essentially asking how people are funding the digital navigator role at this time, which I think we may have answered a little bit. And then the
Hmm.
second one, I imagine that patients and individuals and possibly providers are often worried about the cost of using these platforms and how is that typically addressed. So we do have these kind of emerging,
Hmm.
these emerging billing codes. Is there anything else that you want to add to that?
Yeah,
Go ahead, Jenna.
I was just for that one. So the new codes, they reimburse the provider. And
Yeah.
so that is so basically a provider would essentially have a contract to to offer a digital treatment to their patient. Sorry, they'd have a contract with a digital treatment manufacturer. And every time they offer to their patient, they would then submit for reimbursement. And probably around the same time, they would also get a bill from the digital treatment manufacturer. So that is essentially how reimbursement is happening. It is meant to ensure that providers are not, paying out of pocket for
Hmm.
digital
Hmm.
treatments.
All right.
Yeah.
Oh, go
I
ahead.
was going to say beyond that, then it's kind of more traditional contracts where a payer or a health system is looking at, sorry, a health system looking at continuous care, wanting to add a digital layer, making the investment to learn to see, say, in a collaborative care model or a hybrid care model, where can that best fit and sit, and which population does it best serve. So often there might be either a 1 year contract or 3 year contract where you get to really get that working. I think that's for the non sort of PDTs still the avenue to do that. And then often within that, there's an ability to fund that digital navigator role because that isn't the sole role they have. It's usually a non-billable role, BA trained, somebody who can act as that care coordinator or care navigator. So they would their sort of remit would be broader than the digital tool, but that would be one of their pieces of their portfolio. So I think if you even go into PubMed and look at digital navigator, you'll kind of see how systems are using that to give you some sense of what the qualifications are. But usually it's somebody who is part of the healthcare team, non-billable role.
Great. All right, another question here. Thank you. Great discussion. I'm Kevin Murnane, an adjunct at Kellogg in engineering at Northwestern University.
Ah, mhm.
We are developing initial programs and surveys on mental health and leadership. We have so much to learn, and our technical students want to contribute to digital solutions. I feel like we're at the very beginning of understanding how to help struggling students and business leaders. I'm constantly meeting with students and executives who could benefit from your work. How can I learn more to help our students and to support your work?
Okay. So, David, are they affiliated with Northwestern University? Then that
Yeah.
might be you. So talk to David. But I'd be happy to chat with you as well, Kevin, because it really is the melding of skill sets and mindsets that get us to success. And I think that's the beauty of digital mental health is you have folks coming in with lived experience starting companies. You have folks who really want to help evolve the system who are bringing in very sort of different mental maps. And I sort of personally welcome that because I think that makes us all better in terms of how we get past this early adopter, in terms of the innovation cycle, how we get past that to the late majority.
Yeah, certainly I'll underscore that. I'm happy to talk with you, Kevin. The other thing use this to give a plug to the Society for Digital Mental Health. So
Absolutely.
you can look that up. I think it's www. I have to check, but
Yeah.
I'll put it in the
If you
chat.
Google it, you'll find
But
it.
there
Yeah.
is if you Google it, it should come up. And
Hmm.
there's an annual conference in
Yeah.
June,
Couple of weeks.
which is virtual, so easy to attend. That would be another good way of help of you and your students getting familiar with the field.
There certainly can be like internship or probably other programs too at some of the digital
Hmm.
health tech companies. I don't just because it says engineering. So, I don't know if that could be something to keep an eye out for.
Yeah, and in fact, the
Hmm.
society has a program that I don't know if you were involved in putting that together of matching people with internships with companies. So
Hmm. Hmm.
Brilliant.
I don't see any other questions at this point. So go ahead and type them in. So I guess there's lots of things that we didn't cover. So I'll go ahead and maybe go back to one that is that I'm kind of personally interested in, and that is these tools we've talked about mostly about kind of where in the care pathway is it best to kind of situate these tools or these kinds of programs. So we talked about like primary care is one that's come
Mhm.
up over and over again, which makes a lot of sense. Um,
Mhm.
there's also been attempts to just kind of make it available on
Mhm.
the healthcare center's website, or first line treatments, or in mental health clinics when there are waiting lists. Are there sort of places that work better or that don't work as well for getting people connected?
Trina, I bet you have a very good view of this from KP. We might get
Yeah. Yeah, well, I think it depends the tool for the care setting. So, in my experience from the healthcare side, I would say, KP built out an ecosystem approach which has multiple tools. So clinicians might start somebody on, say, mindfulness meditation as a tool because that's kind of where they're ready to start. And then maybe at the next visit, then they're ready to do some work with CBT because CBT is work. You're tracking your negative thoughts. You're reflecting on that. It's not the same as mindfulness meditation. Of course, many of the CBT tools have those embedded as well. So I think it's not a one size fits all. So in primary care, you might be having somebody starting a medication. We know that takes multiple weeks to take effect. So they're getting a tool in addition to augment that plan of care, or they don't want a medication, they're willing to try a tool. In specialty care, obviously, you have um, therapists and psychiatrists who are knowledgeable about CBT, and then they're able to leverage the tools in between sessions. So, to give life work or homework or whatever parlance you want to use to frame that, but it brings to life and concretizes what happens in the therapy session and reinforces that between sessions. I've seen that used to very good effect. I've seen newer papers and Stephen Schuler, who isn't on the call, and maybe David, you're involved in this as well. Where libraries are getting involved and engaging younger people and being a place where tools can be both administered to folks. And obviously schools and universities being another setting where people can hear about things. So I think we really are still beginning to map the optimized spaces and places. If you think about things like measurement-based care, there's still just about 30% penetration in the US about that. So it's really a marathon, not a sprint, to finding out all of these places. But it really starts with is somebody ready to try something, and do they feel confident enough in their technological abilities to get going, and then having a really good experience when they're in there, because that's the side of the industry to get the solution to be engaging. But so many steps between then. And what I've discovered is if somebody is saying, no, I don't want therapy, even if they may meet the medical necessity for it, a tool can often get them ready for that journey, because now that you've normalized, educated, destigmatized what might be going on with them, and they've got some of the vocabulary to understand what's going on, and then they're ready to try. So I wish it were a simple answer, but I think we're still on our learning curve on that one. Jenna, what else would you say?
Well, the only thing I was going to add is for us, like density of relevant patients is key. So
Hmm.
actually, primary care has been a little bit harder for us for sleep because it's not as dense as sleep medicine or psychiatry, where
Yeah.
50% or more of their patients have insomnia. And so because if you think about the provider behavior change,
Yeah.
it's going to be coming up a lot for them to be motivated to get into the habit of
Hmm.
doing something new. Primary care it's very important and they are motivated, but it's a little harder because it's just not coming up in every single visit. So I think, they both work, but it's that density of relevance for the patient, I think, and provider matters.
Yeah. Great point.
All right. Well, we are at the top of the hour here, so I apologize. There's a few more questions that came in that we won't have time for, but or do you have a moment or two? There's one question here from Ricardo Munoz about prevention, which is, I know, something that a lot of people think about.
Hmm.
Oh, that's wonderful to have Dr. Munoz on the call. Gosh, that's really interesting. I don't, I mean, there's just to say, I think um, FDA views, prevention as a high bar for proving. And so I think from there is certainly possibility for there under the kind of FDA CMS reimbursed pathway for there to be reimbursement and broader distribution of preventative treatments. Uh, there aren't any yet, but I think that could happen that way. And then I think obviously, Trina, as you were talking about before, there's also, lots of the maybe not making full prevention claims, but getting people what we would consider to be important early education
Mhm.
that we know can have good preventative effects. So I think both of those could happen, but it is a question of, who's paying for it, how are
Who's
they
paying
getting to
for it?
people, and I think there's different models there.
Yeah.
Yeah.
Yeah, payers and employers are interested in that prevention piece for sure, um, because of the population that they cover. So the segmentation works in that setting.
All right. Well, we are now a little past the top of the hour, so thank you for staying on a little bit longer. And Trina and Jenna, really thank you for taking the time out to talk with us.
Pleasure.
This I certainly enjoyed this. So
I enjoyed it and I learned a lot. Thanks.
hope to
Thanks to
see you
both of
both
you.
soon.
Take
Absolutely.
care.
Thank you so
Yeah.
much.
Take care
Bye-bye.
and yourself.